Good afternoon, everyone. Thank you for joining us today for our weekly endocrine grand rounds. So we are very happy today to have one of our senior fellows present his clinical research project. This is a tradition that the last endocrine grand rounds will be presented by our senior fellows who are finishing and have done some work on any aspect of endocrinology that they're interested in. So Rahul Pansare, he graduated from Lokmanya Tilak Medical College in Mumbai, and then he came to the United States where he did his residency at Mercy Medical Center in Michigan. He had excellent reviews from there and won awards for being an outstanding resident. So we thought he would be a good choice for us. So we selected him to come to Louisville, and he did not disappoint us. He has been an excellent fellow, very enthusiastic, energetic, and very interested in endocrinology. So today he will be talking to us about cystic fibrosis-related bone disease. He will be graduating tomorrow. you know, the graduation ceremony is tomorrow, but the certificate will be given later, and he will be not too far away, up in Henderson, Kentucky. So we wish him well, and we look forward to his talk.
Thank you, Dr. Mok, for the wonderful introduction. So good evening to my virtual and the audience who's present here live. My topic for today is cystic fibrosis-related bone disease. So I have no disclosures today, and I have two main objectives. One is to discuss the pathophysiology, and second is the diagnosis and the evaluation of cystic fibrosis-related bone disease. It really took two heat waves for us to discover cystic fibrosis. This was the first heat wave, which was in 1938, during which time Dr. Dorothy Anderson uh, paved the way to the discovery of a completely new disease, which she called cystic fibrosis. And she noticed that individuals, 49 of them who had some kind of a pancreatic disease, went on to develop very bad lung infections and salt loss during this heat wave. Subsequently, there was another heat wave in 1950s when Paul DeSantignis and his colleagues said that there was some kind of a sweat defect, and those individuals had presented with a particularly bad heat prostration in this NYC heat wave, and this was in 1953. It wasn't until 50 years later in 1980s that we finally were able to figure out the gene that was encoding the CFTR channel. And the CFTR stands for the cystic fibrosis transmembrane conductance regulator. As you can see here in the panel adjoining, this is the normal CFTR ion, or rather ion conducting channel. And you can see the chloride ions, which are predominantly intracellular, escaping out through this channel into the extracellular space. A defective channel results in mucus plugging, as seen here in the mutant CFTR channel. After this discovery, there are a total of 6 defects which have been studied, which affect this particular the production of this channel. So as you can see in this normal pathway, the CFTR DNA is first transcribed into the RNA. Then the RNA gets translated into the nascent CFTR molecule or protein. And then this is nicely wrapped up by the Golgi apparatus and then finally presented on the surface of the cell. Defects during different stages of this process result in 6 different kinds of disease processes. And the most common one is the type 2. Oh, wait, hold on. Is this not moving ahead? I don't know, it just stopped. Kelly.
Technical difficulties. Let's see.
Jump slides. Yeah, behind 60. Yeah.
Is that okay?
Yes, yeah. Yes. Sorry about that. There was some technical glitch here. So as you can see, the number 2 variant is the most common. And here, the protein, the nascent CFTR protein is produced. However, it's misfolded and it results in protease destruction of the protein, resulting in complete absence of the functional CFTR molecule here. And the one of the genes involved there is the phenylalanine 508 deletion. So there are almost 25 different genetic mutations which have been identified. The most common of which is the phenylalanine 508 deletion. And this data was gathered from the CF registry, which had almost about 32,000 individuals in 2021. And as you can see, almost 27,000 of them, or 85.5% of them, have this common mutation. This was another interesting study that I came across. This was done by Jay Kelly. And what she did was she gathered data from all the different CF registries that exist all across the world. And as you can see, United States, and this was in 2017, United States even then had the most number of cases of CF, almost nearing 30,000. But keep in mind that the US is also the third most populous country in the world. So the prevalence is really just 0.09%. And in case you're interested, Ireland is the country with the highest prevalence. Within the US, you can see that Kentucky has about 620 cases. And out of these 620, 100 plus cases or so, we see in our clinic for management of endocrinopathies that are seen in CF. This is the overall prevalence of CF. And here I wanted to highlight how in 1991, when only 32% of the individuals were over the age of 18, as of 2021, almost 58 or nearly 2/3 of the individuals are now about 18 years of age. One of the reasons is because of the advancements and the progress that we have made through CAFTA and other medicines for CF. You can see that at present, the median age of death is 33. However, it has been predicted that individuals who were born in 2017 to 2021 would go on to live till the age of 53. And that's just going to result in a higher number of individuals who are over the age of 18. This is the same chart which really shows at present how most of the individuals are between 10, 20s and 30s, but you can also see that individuals are living till almost more than 70 as well. This is another slide which shows the epidemiology. It's a busy slide, but I'll draw your attention to a few important things. One is the total number of individuals with CF, like I said, in 2021 are around 32,100. Out of them, the mean age is around 23 years. 58%, like I showed in the previous slide, about 18 years of age. Most of them are white, 91%. But you can also notice that individuals of other race, as well as of the Hispanic race, the incidence is increasing, or the prevalence is increasing, and roughly about equal number of individuals are men and women. And like I showed in the previous slide, the median age of that at present is 33, but that number is going to increase to 53 in the near future. So these are some of the endocrine manifestations of CF that we commonly see. The ones which are highlighted in red are the ones which we see in our clinic. They are growth failure, vitamin D deficiency, hepatic steatosis, bone disease, diabetes, and then reproductive health. including CBAVD and infertility. Again, this was another interesting data collected from CF registry, which shows the most common presenting feature of individuals with CF at the time of diagnosis. And the only reason I put this slide was I wanted to highlight that almost 9% or 1 in 10 adults who were newly diagnosed in 2021 had some kind of infertility or CBAVD, which was the presenting feature. So that's kind of an interesting thing. Now, finally, coming to my topic for today is the CF-related bone disease, and it's commonly called as old bones in young bodies. And this has been researched since 1980s, 1990s. In terms of epidemiology, there's a stark contrast between what you would be typically the osteoporosis that we see in adults, which really starts at the age of more than 70s when we start screening for men, and for women it's post-menopausal. Here you can see most of these individuals actually are seen are starting as early as 20s into 30s and 40s, and obviously even into old age as well. So why is this CF-related bone disease important to know? It's important because the prevalence is really high, almost 13 to 34% in many of the studies that have been published. There's also a very high incidence of fractures, almost 20% and 27% respectively for non-vertebral and vertebral fractures compared to healthy individuals. And it is also associated with very high morbidity and mortality. So here you can see that there's a lot of pain, there's a lot of long-term deformities, ineffective chest physiotherapy, poor airway clearance, and ultimately all of this in individuals with CF results in pulmonary exacerbations and rapid decline in lung function. This was a very sad case that I saw online, published on PubMed in 2005. And this was a young patient who actually presented with a sternal fracture, and that proved fatal in her case. So moving on to the etiopathogenesis now. What exactly causes CF bone disease? So just because CF is such a multi-organ disease, there are multiple things that contribute to it, and truly the pathogenesis is multifactorial. One of the things is pancreatic insufficiency that causes fat malabsorption. And as you know, calcium binds to fat through a process called saponification. And when fat is malabsorbed, calcium gets excreted as well. Certain fatty acids are also associated with low bone mass, in particular palmitic and docosahexaenoic acids. And remember that along with the calcium, certain fat-soluble vitamins such as vitamin A, D, E, K are also lost. And for us, of particular importance is vitamin D, which we all know is important in bone health. And the other important vitamin is vitamin K, which they say is involved in carboxylation. So in order to for the body to have a good osteogenesis process, we need carboxylated functional osteocalcin. And the lack of carboxylation causes impairment in osteogenesis. And the last thing, as the pancreatic insufficiency progresses from the affecting the exocrine function to affecting the endocrine function, these individuals lose their islet cells and eventually develop diabetes. And we call this diabetes as type 3 CDM. A little bit more about diabetes. It's the vitamin D deficiency itself. We typically want to keep the levels between 30 to 60. That's considered optimum with, there's consensus for those to maintain vitamin D in those levels. The deficiency of vitamin D causes two things. One, it causes PTH to rise, which is secondary hyperparathyroidism. And it also decreases the calcium absorption. And both those things ultimately result in increased bone resorption. Vitamin D also is involved in a number of non-skeletal functions, which are also very important in CF patients, because the vitamin D has antimicrobial defense functions, immune response stimulation, and even possible control of chronic inflammatory response, all of which may be impaired in individuals with CF. The next important thing is growth retardation. So we know that a low BMD is associated with malnutrition. And we know all the CF people are prone to develop malnutrition. However, even in individuals who have optimal nutritional status, they may still have a low BMD, meaning that the CF itself may have a direct bearing on the BMD. The other thing responsible for a low BMD could be body composition, in particular the lean body mass, because we know that lean body mass is important for maintaining a mechanical force, the pull and push on the bones. And studies have shown that individuals who have a low bone mass, a low lean body mass, also are less physically active and are more nutritionally compromised. One of the mechanisms of action that they say is possibly through deficiency of IGF-1. And this is not really of pituitary origin, it's more related to the liver disease that is commonly seen in CF. And the lack of IGF-1 may cause, may be implicated in protein anabolism, as well as may have some bearing on endocrine and paracrine regulation of osteoblast proliferation and differentiation. The next important thing is reduced sex hormones. As we know, puberty is related peak growth velocity is quite important to accrue a good peak bone mass. Historically, it had been shown that maybe delayed puberty is one of the clinical features of CF, although now there are studies to show otherwise. But still, these individuals do present with delayed puberty. And one of the common factors attributed to that is the chronic nature of the disease, the poor nutrition, and the medications that we take, such as steroids. Interestingly, in spite of good nutritional status or clinical status, the individuals may still present with delayed puberty. And one of the things that they attribute to is possible modulation of the reproductive axis by CFTR. So I came across an interesting study where this was an in vitro study where they took the pituitary cells and they on purpose deleted the CFTR gene, and they noticed that there was some downstream dysregulation, or the GnRH pulsatility was affected because of this lack of the CFTR gene and its products. Cystic fibrosis is also associated with a lot of inflammation. And as we know, the bone remodeling is influenced by a lot of systemic hormones, cytokines, localized growth factors. Some, to name a few, which may have some direct bearing on the osteoclastic bone resorption. These are TNF-alpha, PTH, VEGF, which is vascular endothelial growth factor, interleukins 1, 6, and 11. In particular, there are studies to show that interleukin 6 might actually be associated with annualized declines in BMD. There was also an interesting study which showed an association between the number of IV antibiotics and the bone mineral density. And really, the antibiotics have no bearing on the BMD, but it was really an indirect evidence which linked inflammation cytokine production to bone health. Because if you're ill, if you're sick and having frequent exacerbations, you would tend to receive more IV antibiotics. And subsequently, because they were sick, they would also have low BMD. And lastly, the glucocorticoids. And as we know, individuals who are taking 5 milligram or more for 3 months or more in a year are predisposed to develop osteoporosis or low BMD. And the most common mechanism of action for steroids is pre-apoptotic, or rather release of pre-apoptotic molecules, which results in apoptosis of osteoblasts, as well as activation of RANKL and macrophage colony stimulating factor, which results in higher number of osteoclast activity. And both of these result in increased resorption and decreased bone formation. And again, steroids themselves might have an effect on the reproductive axis, causing a suppression of that because of prolonged use, which again contributes to this CF-related bone disease. So now finally moving on to the diagnosis part. This is really an extension of the osteoporosis, pretty much has a lot of features which are overlapping with any typical osteoporosis that we treat. The only difference here is you do have to consider the age. If the individual is less than 20 years of age, you would look at the whole body and the lumbar spine, because these are individuals who are growing and they have the height is kind of increasing, and that could affect the BMD. And if the individual is more than 20 years of age, you would look at the lumbar spine and the proximal hip. And I would like to emphasize the importance of an endocrinologist reviewing the film by themselves, because here you can see how, this is particularly not a very good BMD DEXA scan, because you can see the Watts triangle is included in the femoral neck, which typically needs to be excluded in order to measure the bone density. But anyways, when considering the diagnosis, you look at typically the Z-scores and the T-scores. So if the patient is premenopausal women or men less than 50 years, you look at the Z-scores. If they're postmenopausal women or men more than 50 years, you look at the T-scores. Very often in our clinic, we noted that many of the individuals would actually, the reports would say T-scores in spite of them being young at 30 years of age. So the guidelines do say that you could accept the T-scores if the Z-scores are not available over the age of 20 years, but ideally those individuals should have Z-scores available. So what really is osteoporosis, or who would need treatment? So in individuals less than 20 years of age or those who are young adults, a Z-score of less than -2 or a low trauma fracture, they would potentially be candidates for bisphosphonates. And the second would be if it's a postmenopausal, and this is something similar to what we do for usual osteoporosis, postmenopausal women and men over 50 years of age and T-scores of -2.5. So here I did want to make a distinction that when you're looking at the T-scores, it's -2.5, but when you're looking at the Z-scores is -2. In terms of screening, all the adults require screening for CFBD. In children, they say if it's their idle body weight is less than 90%, they would qualify. Anyone who has FEV1 less than 50%, who has prolonged steroid use, delayed puberty, and history of fractures. All of them would definitely need an earlier CFBD bone screening. Coming to the prevention part now. Because cystic fibrosis-related bone disease is such a multifactorial and multi-organ disease which is affecting multiple organs, it's important to emphasize a multidisciplinary approach, because only an endocrinologist would not be able to treat the CFBD. It's important that their nutrition is optimized and we get them closer to their goal BMI, as well as help them attain a higher lean body mass. And second, making sure that the CF pulmonary exacerbations are promptly treated and to keep them at the minimum. Because as we had reviewed in the previous slide, higher the number of exacerbations, the more would be the bone loss with each exacerbation. Subsequently, and this is, I had taken it from, this slide looks busy, but I had taken it directly from the European Cystic Fibrosis Bone Mineralization Guidelines. So I'll highlight a few important points here. One of them is the starting dose is slightly higher, 1,000 to 5,000 international units per day of vitamin D2 or D3. They do say that they favor D3 over D2. For calcium, depending on the age, it's 1,000 to 1,200, and this is pretty much what we do in non-CF individuals. And they did say to increase dietary sources of calcium. Again, coming to vitamin K, this is recommended for all individuals with pancreatic insufficiency. And then the dose that they recommend was at least 1 to 10 milligram per day. So now coming to the treatment part, finally, it's important to optimize the vitamin D and the calcium supplementation, sex steroid hormone replacement if there's evidence that there's a deficiency for the sex steroids, and then ultimately minimizing the use of glucocorticoids whenever possible. But the mainstay of treatment really is bisphosphonates. Like I had previously reviewed, anybody who has a low trauma fracture, a lumbar hip or a total hip or a femoral neck T or a Z-score less than -2 or less, and significant bone loss more than 4% per year on serial DEXA measurements. a T or a Z score less than minus 1.5, and awaiting a solid organ transplant or prolonged glucose use would also qualify for bisphosphonates. Like we always do with bisphosphonates, it's important to make sure that the dental appointments are up to date, counsel those individuals with for osteonecrosis of the jaw, ensure that they do not have esophageal disease, which would be a relative contraindication to oral bisphosphonates, like liver cirrhosis related esophageal varices or even severe acid reflux. And then monitor the kidney function. Remember, GFR less than 30, we typically avoid the bisphosphonates, and ultimately contraception use in order to avoid unnecessary exposure to the unborn child. I looked up denosumab, and I honestly did not find much data. There are no studies. So I'm moving on to the anabolic agents. There I did find a few case series for teriparatide. This particular case series had 4 patients, and they showed there was a positive change in the BMD. But again, they said that because this is a case series, there is a need for larger studies to really show a positive effect. And then coming to romosozumab, there was also just a single case that was treated with it. This was an interesting case again, and I believe it was a woman in her 40s. And this particular patient, and you can see from 2014 to 2019, they had received Actonal orally, and then but their bone mineral density had barely changed. Then in 2020 is when they received the romosozumab. And the following year, you can see that there was a marked improvement in the bone density. For the lumbar spine, there was a 17.8% change. And for the total hip, there was a 12.8% change. But then again, this is just a single case, and we would need much more extensive data and other studies to really conclusively show that romosozumab would be a good choice for individuals with CF. Now coming to Trikafta. Trikafta has been used for a while now, and this was one of the first studies showing the metabolic effects of Trikafta on the bone. So this particular study was a single center study, and they looked at BMD and body composition for 3 months after Trikafta, which was the study group, versus 2 years earlier. And in individuals with CF who are not given Trikafta served as the controls. Along with the BMD and the body composition, they also looked at several other things like the spirometry, the lung clearance index, sweat test, 6-minute walk test, and the cardiopulmonary exercise test. They had a total of 9 study patients and 9 controls. They were aged around 18.6, so they were adults, but plus or minus 4.7 years. And in the study group, meaning the ones who received the Trikafta, they showed that the BMI as well as the hip and the spine BMD increased significantly versus the control group, where there was no significant difference in either the hip or the spine BMD. Further, they also said that the lean body mass, the person fat Z-score, and this actually fat mass divided by height meter square, and that's called the fat mass index, which also increased significantly in the study group versus the controls. The 6-minute walk test improved, the FEV1 predicted increased, and the sweat chloride decreased, as well as they had overall better ventilatory efficiency. So this was one of the first of its kinds, a study looking at how Trikafta affects, and it largely had positive conclusions. Last but not the least, I wanted to look at how lung transplant affects CF bone disease. And I found 2 studies, one of which was published in 2021. So this study was from Canada, and they really looked at, this was a retrospective study where they looked at 131 individuals, all of whom had undergone lung transplant from 2000 to 2015. And then they followed them, or rather retrospectively, they saw them for 10 years post-transplant. And 53% of them were men, with a mean age of 28 years. And almost all of them, 94%, had received bisphosphonates. But they did see that for men, there was positive to little change in the lumbar spine BMD. For women, there was actually a negative change in the first 5 years before improving at 10 years in the lumbar spine BMD. And similar changes were seen in the femur BMD. So you can see, at least for men and even for women for that matter, at the 10-year mark, there was little change in the BMD, not for good, not for worse. However, we don't always only look at the BMD, we also look at the fracture percentage. And what this study showed is that almost 27% of these individuals had a fragility fracture, meaning almost nearly a third. So the conclusion of the study was that lung recipients with CF still remain at a very high risk of skeletal fragility despite of prompt initiation of post-transplant anti-osteoporosis therapy. There was another study, and this was published this year in 2023. This was from Dallas, Texas, and again this was a retrospective study where they looked at a smaller pool of patients, 59, and this was a little interesting because they were not all CF individuals. All of them did undergo lung transplant between 2016 and 2019. However, 30 of them had CF and 29 of them did not have CF. And then they looked at the data and they realized that individuals CF were younger, had lower BMI, had lower BMD scores at all the sites, the lumbar, spine, femur, and the total hip, which was significant. And then they saw that the BMD declined in both groups in the first year post-transplant, lung transplant. However, the interesting finding was that they noticed that the CF patients exhibited a better BMD recovery but continued to have a lower BMD post lung transplant, but the recovery was better than the non-CF counterpart. Does that really translate to a better fracture score? And the answer is no, because in both the groups, in CF, almost 30% had some kind of a post-transplant fracture, and in the non-CF group, 34% had some kind of a fracture. So the conclusion was there was a discrepancy between the BMD, the way they responded in BMD in terms of the fracture scores. And they say that this highlights the unique contribution of cystic fibrosis disease process to the bone health. And they said that there's a clear need for better prevention and treatment of osteoporosis in CF before and after lung transplant. So ultimately, this was an interesting algorithm that I found in one of the studies, and this was published sometime back in 2005. And seems like a very busy and a very chaotic slide, but really what they're saying is that you group the patients into three groups. Those who have a BMD of more than -1, and in them you focus on nutrition, meaning vitamin D, calcium, vitamin K, target BMI, exercise. And then if the BMD is worse, meaning between -1 to -2, you add another layer of care in terms of pulmonary and endocrine management, meaning aggressive treatment of pulmonary exacerbations, making sure the diabetes is taken care of, their puberty and hypogonadism is treated, endocrinology referral. And if they have some of the clinical features like if they are receiving steroids, if they are about to get a lung transplant, then you could consider they would benefit from bisphosphonates. And ultimately, the third group is individuals who have a bone density less than -2, and in them you would add another layer of care, meaning along with the nutrition and along with the aggressive pulmonary and endocrinology care, they would also need bisphosphonates. So the ongoing research that I participated in was the title read Correlation between BMI and estradiol levels and BMD in men with cystic fibrosis. So this is really focusing on men with CF, and the goal was to look at the prevalence of osteopenia and osteoporosis, and also to determine if the BMD is related to BMI or serum estradiol levels, and also to look at how the lean body mass, the adipose and the muscle tissue, whether they are predictors of BMD in men with CF. And the study was started way back in 2019. And actually, there was also a abstract that was presented in Endocrine Society in 2020. This was pre-pandemic. However, at that time, the body analysis, meaning the muscle and the adipose tissue mass data could not be collected. So now hopefully we are reviving it and have started collecting data on this. And so far, out of a total of 50 or so men with CF in our clinic, we have been able to gather data for 7 of them. This is the in-body analysis which we are using. And it gives a number of parameters, including, the total fat mass, the lean body mass, the total BMI, and so on and so forth. So although I could not complete the study, I was very thankful to my program director, Dr. Krishnasamy, who actually exposed me to this kind of a study, gave me an opportunity to get my feet wet. And it was a great learning experience for me to just be part of it, to know more about the cystic fibrosis-related bone disease. And I'm really great for all the knowledge that I could gather through this study. So these are my references. I would like to thank the University of Louisville Cystic Fibrosis Center, in particular Beth Favie, who's the nurse coordinator, Lila Healy, who's the nutritionist there, who has helped us collect some of the body analysis data, all the CF team members, along with the physicians working there, the clinical trials unit, and obviously my mentor, Dr. Krishnasamy, without whom I could not have participated in this, and this could not have been even a part of my educational opportunity. So thank you so much. And again, thank you. So this is today's CME.
Curious about the preference for bisphosphonates in the group. Is there a preferred option for what we do here as far as for our adults with CF? We in pediatrics, we primarily use just 2 infused versions, pimidronate or zoledronic acid. So I was just wondering what your
very, very good question. So the question is, what's our preference in terms of bisphosphonates, pamidronate versus zoledronic acid versus oral. So, and Dr. Krishnasamy can correct me, but typically we use either oral bisphosphonates or we may use zoledronic acid. Yeah.
But some of them, especially the transplant combination, they do very well with drugs. Some of them prefer to use the oral, like either residual or interestingly, the patients who were transitioned to from pediatrics, I've seen them on the daily dosing. To me, in adults, they don't use it much, although that's what was in the study. But early on, this was in the study. 5 milligrams per day, and I had a couple of patients.
So I think we have a couple of questions here on the. Where did that go?
Do you want?
Oh, yeah, I'm just trying to.
Go to the chat here.
Okay. So yeah, one of the questions was excellent presentation. Is there a genetic predisposition to cystic fibrosis? I'm not quite sure. Are you trying to imply that like genetically, as in passed on, like autosomal dominant, autosomal recessive?
Yes, any kind of genetic predisposition that can be corrected earlier on in life in the future.
I'm not quite sure.
There is genetic predisposition, but as of now, we don't have any information available.
Okay.
Most of the patients who get pregnant, all of these patients do undergo.
Okay, so Dr. Krishnasamy has helped me with this question. She says that although there is some genetic predisposition, we do not have an intervention at this time. However, individuals who are bearing a child, they undergo testing for genetic. They undergo genetic counseling. Yeah. And the kid gets tested as well. Okay, and you mentioned female sex hormones are deficient in females. Are there any male sex hormones that are deficient? So yes, I guess because of multiple factors like the CFTR gene itself, which they are saying, and even for that matter, the steroids, which cause suppression of the hypothalamic pituitary gonadal axis. In men, you would see deficiency in testosterone, and in women, you would see deficiency of the corresponding sex hormone. So yes, we do see that. Yeah. And that's actually part of our study to kind of measure the sex hormones as well. Yeah. Thank you. Yep. That's it.
So you routinely get in body or all the patients coming to see it?
So I think as part of the study, we are doing it, but on the side, even from the nutritional side, they are doing in-body analysis for anyone who has a particularly low BMD.
So there's a particular interest by the gastroenterology faculty who's just joined the who gets to see them a lot for the malabsorption, and he started checking that himself. So and the nutritionist goes next door. It's a very interesting.
Patients to pick up that, I was just asking back here. And so it's it makes me feel old, but the 07 is when we started expanding the newborn screening program in the state. And I'm wondering how many people do we miss now that are born in Kentucky that are aging and maybe are diagnosed as adults, as young adults, or just wondering how many of these are we missing?
Yeah, it's a great question. I mean, the question was that since the screening started only the newborn screening started only in 2007, the question is how many of the adult individuals with CF could we have possibly missed up till now because of the lack of screening prior to 2007. So to answer that question, it would be probably hard to put an exact number, but we do commonly see individuals who are presenting with infertility, or like I said, like I presented in one of the slides, many of them also have CB, AVD as their initial presentation as well, much later on in age in life.
That one who came with recurrent pancreatitis and asked you to hospitals to gastro memorial check. I think Dr. Mukshidin had some of them who just have pancreas problems.
Right, mostly GI, right?
Yeah.
So their lifespan is typically
And then the CBAV, plenty. I do have a few patients who are diagnosed at the after having sign of infections and pneumonia and all that.
So Dr. Krishnasamy added that she has seen individuals who were diagnosed even in their 40s with CBAVD, and even has had patients who came in with recurrent pancreatitis and then eventually were diagnosed to have CF. And then I just saw a message from Healy, who's the nutritionist here, and she says that they try to get all of the CF patients to complete the in-body scans. So to answer Dr. Mook's question, yeah. If no more questions, then that's it.
I have
Thank you.
another
Thank you
question
so
there.
much.
Are
Yes,
there
sorry.
any lessons learned from CF that can be applied to adult osteoporosis?
I think some of the lessons, I think the important lesson here was prevention, and then prompt treatment, I think those are the two take-home messages, because making sure that we avoid unnecessary steroid exposure, making sure other things are optimized, the nutritional like vitamin D, calcium, the diet is optimized. I think that's important to even prevent osteoporosis, and that applies to any adult with osteoporosis. And then subsequently, once they reach the threshold to meet, or rather once they meet the threshold for getting a DEXA scan and screening, they should get screened. And subsequently, once osteoporosis diagnosis is established, they should get prompt treatment for it. So I think that kind of is similar to both whether the patient has CF or no.
Thank you.